Dear Facebook Pure Urology viewers, good evening, one and all. As you know, the today topic is flexible ureteroscope, how to prevent damage to the flexible scope. This topic was given to Dr. Pankaj Maheshwari sir, who is a well-known urologist in the West Zone, as well as in India, as well as some parts of the abroad also, with vast experience. Before we introduce sir officially, like every day, I wanted to ask certain details from the senior persons. Main reason being, every junior should get an encouragement that he has to start from a level of zero at the private practice. Even if you go to an institute, you are a junior. So unless we take the difficulties of the seniors, uh, we will not have positive momentum. Sometimes it may be related to your earning, it may be to your technique, related to your case. You don't get one pyeloplasty for 1 year. You have seen 100 pyeloplasties with some senior, but you don't get a case of one pyeloplasty. Forget about pyeloplasty, circumcision you don't get. But if you keep listening the seniors, that's why I spent 5 minutes of time. Good evening, sir. Pankaj, sir. Sir, as
Good
just
evening, Dr.
we were
Chandra.
discussing, uh, the main reason I got impressed with you is when I have seen your HOLEP before 5 years back. Before that, I didn't know much. After that, quickly I came to know, and conferences we met, and certain subjects like laparoscopy, HOLEP, RIRS, you quickly, uh, from the Western introduction, you could hand over these three in less than 5 years, I must tell. This is the one which is happening now in India. Probably 30 years back may not be there. Once you got the knowledge and equipment, you started. So, where is your MCH training, sir?
You see, I did my MBBS and MS from Government Medical College Nagpur, and then I did my urology from Grant Medical College Mumbai.
Sir,
I
who was
was
your
lucky to have two
who is your
brilliant
HOD, sir?
teachers.
Who was your HOD?
Yes, so I had two brilliant teachers. I began with Dr. Madhav Kamath.
Sir.
Midway in my training, Madhav Kamath sahab retired, and then I was handed over to Dr. Chibar.
Oh, oh, oh.
And I have no hesitation in saying that whatever I have learned in endourology today, a huge credit goes to Chibar Saab.
Great.
Means he is a unbelievable person, a unbelievable teacher, and a brilliant human being to say the
That means
least.
Skipper sir is your professor when you are in MCH.
Yes,
He was in government service, sir.
he was an honorary at Grant Medical College.
Okay.
So he would come to Grant Medical College maybe twice or thrice a week.
But private
But
practice was
what
allowed,
I
eh?
would do is yes, private practice was allowed for honoraries that time.
Okay.
So I would accompany him wherever he would go for his private practice and indirectly learn while helping him in his work. So for 2 years, I have moved around all the major hospitals in Mumbai carrying the PCNL bag of Dr. Chibar.
Great.
And it was probably a brilliant learning time.
Okay. By that time only he was doing PCNL properly in the private practice.
So in the private practice, Dr. Chibar was doing huge number of PCNLs, and his technique of PCNL is probably the most scientific that you would see anybody else doing.
Recently we
Means
have done a
every
program.
step that he takes, there would be. I know, I saw that. I saw that.
Yeah. Yeah, yeah.
Every
Great, sir.
step that he takes, there is a logical and a scientific reason for that.
Okay.
So it was really a pleasure.
After your
After
MCH,
finishing my MCA,
where did you go, sir?
so after finishing MCH, you see, I come from a place called Akola, which is in Vidarbha.
Yes, sir.
And my parents both are doctors. So my initial plan was to start practice at Akola.
Yes, sir.
Because my wife had one more year to go in Mumbai, I decided to get myself trained in few things which I did not see during my MCH and then start practice at Akola.
Great.
So this way, I landed at RG Stone Clinic because I had not independently done a lot of endourology, and JJ did not have lithotripsy.
Okay.
As luck should have it, when I was at RG Stone Clinic, Professor Patnaik, who was there as as a in charge there, Patnaik Sahab resigned, and they offered me the post to take over the center.
Okay.
So that is how the plan, which was initially to go back to Akola and start practice,
Yeah.
I started working in Mumbai.
Okay.
RG was a huge platform because there was a huge amount of stone workload. There was a backup of lithotripsy, so even if you could not clear any stone, you could still, by endourology, you had a backup of ESWL, and you
Yeah.
would
Yeah.
not harm the patient. And though RG is a private enterprise, financially they were very helpful to the patients. So if I would say that, okay, this patient has a problem, don't charge him, they would easily waive off the fees. So that
Okay.
way, RG gave me a platform with a lot of work,
Yeah.
dedicated work, and that is where I came across few friends like Mukund Andankar, Rakesh Khera, who encouraged me into writing publications.
Great.
So one more person that I have to mention here, though I have never worked with him as a student, but who played a big role in my career, was Professor S.D. Bapat. Bapat
Yeah.
Sahab used to come at RG every Wednesday, and the 3 hours that he would be there at RG, I would leave all work and be with him. Every
Okay.
sentence he would say would be the knowledge gems that he had acquired over his years of practice and maturity.
Great.
These were people who really impacted me. Outside, I used to see Mahesh Desai Sahab. It was always an honor and pleasure seeing him. I would observe Dr. Ganesh Gopal Krishnan. So since my first year in MCH, I tried to attend as many conferences as possible,
Very good.
and
It's an important message.
I love to see these various people, just observe how they work. Every person has a capacity to give you one small tip which makes your procedure more easy. Like
Yes.
in one of the conferences, I had seen Ganesh Gopal Krishnan Sahab putting methylene blue in the contrast while PCNL. So when you puncture, you get bluish fluid, and it gives you a very good feel that you are inside.
Yeah.
So for many years, I adopted that, and I thought that helped me a lot. So
Yeah.
like these small tips that you pick up in conferences, they really help you in your work later on.
Very good, sir. Great. Sir, with this introduction, I will officially tell about you the more or less discussed, but it will be nice to, it is already 50 are online. So, as I told you, today we are discussing on a video based technique prevention of flexible ureteroscope damage. As you all know, flexible scope is the one which is costly, and we should not get damaged in early part, otherwise you will lose interest. So Dr. Pankaj Maheshwari sir is MBBS DNB General Surgery, MS General Surgery, MCH Urology, and a pioneer in the holmium laser in urology in India. To be honest, I know him when I started seeing as a second best at that time. Probably they are equal now. Anil Varshne sir I used to see, and then Pankaj Mahesh. These two are the iconic figures in India to do HOLEP, because HOLEP has a steep learning curve. But somehow sir mastered that with 100 watts laser. That time very few people 10 years back who were using 100 watts laser. He started performing this holmium laser enucleation way back in 1998. Even I did not join my MS. One of the initial persons to start therapeutic flexible scopy. That also because I also practice RIRS more. I came to know many of the conferences that he presented. Somewhere in 1999 only he started. We started in 2006. So yes, 50 national and international publication, that is the best part of it, being the private practitioner. And this is the most important sentence, which 8 of the publications are quoted in Campbell's textbook of urology. I must applaud for that. Few unusual surgical procedures were done. One place where I listened about the PCNL complications recently has done 2 years back, pleural complications. That was a very illustrative recording and live recording and then presented. That gave me a lot of good impression. He also laparoscopy assisted PCNL for large calculi in pelvic kidney, laparoscopic repair for spontaneous bladder perforations. He has devised a new technique of placement of CAPD where more than 100 cases he has shown that. He has authored 3 books in urology, I was asking him this book, handbook on DJ stents, if he can give some information where we can get this in pure. I will be very happy if he joins and keep this, because DJ stents are commonly used and nobody knows what it is made up of, how different types. So old books are the best. Like if you want to see TURP, you don't get now books easily. But this type of handbook on DJ stent, one must have it. I don't know which year Sir has written this. Kidney Se Parichay was written in the World Kidney Day to provide information to lay public man, stone disease and prostate enlargement. Introduction to kidney disease, this was accomplished for lay public. That is actually service to society. Even in my clinic, I have a small book. People say you have put a lot of efforts to give that knowledge. These are all things which keeps you motivated, things moving, and then most important is writing 50 publications. I really appreciate that, sir. And with this introduction, I will hand over the program to you. Now, already Sanjeev Palmer, thanks Dr. Pankaj. I have learned everything from you. Because of you, I have reached a global position. This is by Samir Pamar. First comment already before you started. So like you have mentioned Chibbar sir name. See, there are people who are mentioning your name. You should be proud of that, sir. Thank you.
Uh, Dr. Chandra, I'm really, I don't know what word to use, but I'm really happy at this kind words that you have said. Uh, yes, friends, it has been a journey. It was nice that Dr. Chandra pulled out this introduction online and then went through it in so many details. Uh, One of the small philosophy that I had since the time I joined RG was to keep on floating. New things come your way. You try to pick up whatever you can and then improvise it to your situations. When I started doing HOLEP way back in 1998, I was the first person in India doing it. Means the story goes like this, that when I was at RG had a NDAG laser, and all of you who have used NDAG laser know that NDAG laser practically does nothing to the prostate. So after doing around 15-20 cases, I stopped doing NDAG laser. In one of the World Congress, or I think Asian Urology Congress, I met Peter Gilling and I saw his video on HOLEP. And suddenly it was something like a love at first sight. And I thought this is something which would work. I could convince the owners of RG Stone Clinic to buy that. And since then, this started. Because we were the first center to start doing it, obviously, it was a journey where we made errors, learned, relearned, and things kept on moving. So thank you very much, Dr. Chandramohan, for
Sir,
this invitation and introduction. I am really honored to be here.
sir.
You said so many good things about me, but Dr. Chandramohan, there is so much to learn from you, undoubtedly. You are a wonderful urologist, a brilliant human being, and most importantly, the work that you are doing on this site of pure urology definitely improves the urology, but it shows your pure dedication. It shows your dedication to improve the field and to be a better teacher. This is really what is the need of the hour today.
Thank you, sir.
Friends, recently in a sectional meeting of American Urology Association, Dean Asimov said that in future all stone surgeries would be retrograde. This may be too big a sentence for Indian situations where we see giant stones. Even today, we see large Stepan stones. But this just shows where the world is moving. Flexible ureteroscopy is become a iconic surgery for urology. Like few decades back, anybody who did TURP called himself a urologist. Then that position was taken by PCNL, and probably now that position will be taken by flexible ureteroscopy. That to be called a good endourologist or a urologist, you should know how to do a flexible ureteroscopy. It is definitely not an extension of rigid ureteroscopy. It has its pros and cons. It has its learning curve. And definitely, this is a technology and technique for the future. This technique is used not just for stones, it is used for many other indications, maybe upper tract TCCs, strictures, diverticulars, parapelvic infected cysts, and so many other indications. where flexible ureteroscopy would be done. But stone remains a most important indication. It is giving a tough competition to rigid ureteroscopy for upper ureteric calculi, because when you do rigid ureteroscopy and stone gets pushed back, there is nothing much you can do. But when you have flexible ureteroscopy, you can go up, chase the stone and remove it. It is giving definitely a good competition to PCNL for smaller and medium sized stones. And it is giving a huge competition to ESWL, where the position of ESWL is being discussed in urology today. So though it's a very, very prime technology and a very important technology, a technology which is improving every day, uh, there are problems with this technology. The instrument is reasonably fragile. There are reports where they have lost a scope in less than 3 cases. Few people quote that they have lasted their scope for 500 cases, but average where multiple people are using a scope would be around 40-45 cases. Further, not only the purchase, maintenance, and if you end up doing repairs, all is very costly. Here I would say that the first ureteroscope that we had purchased in 1999, that lasted for around 48 cases. Second ureteroscope lasted only 4 cases. So it is not just your learning curve, but it is also your nature of adventure which decides how you traumatize your scope. So what are the factors that affect the longevity of the scope? Definitely the design of the scope is very, very important. With more number of users, the risk of damage increases. There are many patient factors we would come to, like say if I am treating a patient with a tight ureter, if I am treating a patient with a pelvic kidney or a horseshoe kidney, or a very large lower calyx stone, any anomalous kidney, the deflection that my scope would need would be extreme, and that would theoretically risk my scope. And there would be personal factors as to how we handle this scope. The proper handling is needed before surgery, during surgery, and after surgery. And as our experience increases, we definitely learn to manage this scope better. Various modes of damage can happen. The most common damage is impairment of deflection. So a standard deflection of the scope is 270 degrees. And this is a deflection that you need to get into the lower calyx. With increasing use, this deflection gradually reduces. When the deflection goes below 210 degrees, getting into lower calyx would become extremely difficult. When you push the scope aggressively, you can cause a dent on the shaft coating. Now, though this may not look very bad, and you may feel that the scope is still usable with this dent because the instrument channel doesn't get compromised, this can have very, very significant ramifications. We will come to that. Once the shaft gets bent or the shaft gets kinked, then the scope becomes not much usable, because you will not be able to put the laser fiber or your baskets to do your procedure well. And the most important thing that could happen is progressive black dots that appear on your screen, and the image quality gradually reduces. So the commonest damage is deflection mechanism impairment. You could damage the inner sheath because of laser and the equipped instruments that you use. You could damage the fiber optic bundles by firing the laser inside the ureteroscope. As we have said, deflection mechanism gradually reduces with increased number of users. It also, the most important reason is when you do a intraoperative extreme forcing. So if you try to press that lever with all your power and try to keep the scope that way, you will definitely break the deflection mechanism. Shaft damages always happen because of manual forcing. The image would reduce as you progressively do more cases. One again important reason for loss of image is the leak inside the inner covering of the instrument channel. This leak again happens because of the hand instrument that you put in the flexible scope. And once this leak starts, with progressive use, the image quality gradually reduces. You will realize that whenever the scope gets lost, there is always a relatable event. You would know when you have caused the damage. You were trying to be forceful in the lower calyx. You were trying to be forceful in one of the awkward, say, infundibular rather ischemic calyx of the horseshoe kidney. Now, these are situations when you are trying extreme maneuvers by your scope, and that is when damage to the scope happens. The extreme example of damage is a retained ureteroscope. As I had said, when the shaft gets dent or when the coating of the shaft gets ripped apart, don't try to continue to reuse this scope, because if you put the scope in and if this coating gets crumpled, your scope would get stuck inside. So this is a very interesting report where they had two patients where, because of the ripping of the coating, there was a crumpling of the coating which they called as accordion like distortion, and because of which the scope got stuck in the lower ureter. Like if you can see in the image here, that's the thickened portion of the scope that is seen. That is because of the accordion like distortion. And again here, rest of the scope looks good, but the terminal end is thick. In one of these two patients, they could maneuver endurologically and remove it. So they had to cut the scope by, say, bone breaking instruments. Over the scope, they had to put an access sheath and gradually maneuver the scope back in the access sheath and then remove it. In one patient, they needed an open repair. So this is how the crumpling would look. Here we can see the covering which has got crumpled. Whenever this happens, don't use this scope any further. One common thought is what happens when there are multiple users. Say I work in a corporate hospital where there are 9 urologists. Even Dr. Chandra has a team of 9 urologists. When multiple people use a ureteroscope, definitely the life of the ureteroscope goes down. So what we need is proper departmental user guidelines. If we have departmental user guidelines where we decide beforehand what are the situations where we would stage the procedure, what are the situations where we would say abort the procedure, and what is the duration of the procedure we would maximum go on, what is the size of stone we would do. If we have our own departmental guidelines, the longevity of scope can probably double. If that is not possible, I always thought that probably having one dedicated scope for each person and that person being responsible for that scope would probably be better than not knowing who exactly damaged the scope. This was an old study where they looked at around 100 scopes that got damaged and looked at what were the common damages. So all types of damages are possible: working channel, shaft, deflection component, even eyepiece. And then they looked at what caused these damages. So working channel was most commonly because of laser and instrument insertion. Shaft was more commonly because of the extreme bending and extended use. Optical fiber, again, because of extended use and extreme bending. Improper handling caused damage to the eyepiece and deflection component. So whatever happens, you would be able to know when you cause this damage. You will be able to register that this is the moment I have done a small error and that is how I have lost my scope. Better to avoid these situations than repent losing an expensive scope. So what is the best way to reduce damage to flexible scope? Uh, do not use it. Though as a urologist, I would not want to do this, but definitely I would want to be sure that the place where I'm using the scope, the need for the scope is absolutely essential and important. The risk of damage is directly proportional to number of uses, and I should be very sure that the case is properly indicated for flexible ureteroscopy and there are no other minimally or lesser invasive options available. So before taking your flexible scope out, answer whether the procedure is absolutely needed or can I get the same results by some other modality of treatment. If I can, I should really reconsider my use of flexible scope. Patient factors we have already discussed. There could be anomalous kidneys, horseshoe kidneys, pelvic kidneys, large lower calyx with narrow thin infundibulum, narrow ureter, upper tract TCC, or any patient where the procedure goes very, very long. These are the patients where you theoretically have a risk of damaging these scope. So what is the option here? One option here is you could, instead of using your reusable scope, these are patients where you could use a single-use digital flexible ureteroscope. So this would be a fallback option for difficult situations. So if I have a large stone, lower calyx stone in a horseshoe kidney or a pelvic kidney, I would probably try and do it with a single use digital flexible scope rather than take risk with my reusable scope. OT setup is again very important. It is important to know where you keep your laser machine. The laser machine should be touching one of the legs of the patient. So, because I am a right handed person, I would keep the laser machine touching the patient's left leg so that there is no person who comes between the patient's left leg and the laser machine. So, the risk of laser fiber getting pulled out because somebody accidentally pulled the laser fiber will be taken care of. Further, always keep a trolley below patient's left leg. So whenever you are not using the scope, you can very gently or gingerly keep the scope on this trolley, and you don't need to search for the trolley where you want to keep it. If you can see on this trolley, I have kept nothing. This trolley is reserved only for the scope. So do not have a cluttered trolley. For everything else, there should be a separate trolley, and for the scope, there should be a separate trolley. When you carry the scope, whether from your sterilization place to the trolley or from the trolley back to the sterilization place, I always tell my nurses that it should be carried like a small baby. You don't carry a baby holding the baby by its neck. So don't hold the scope by the shaft or in any odd way. It should be held with both the hands and then carried. So the more you take care of your scope, the longer it lasts. This was a very interesting image I got from Twitter from my friend Dr. Hamri, which shows that there are multiple types of Excel sheets available, and we are really fond of using Excel sheets. The question is, does Excel sheet prolong the life of flexible ureteroscope? Excel sheet definitely helps us reduce the risk of infection. Excel sheet helps us in making the procedure safer for the patient, faster for the patient. It helps us in picking up small stone fragments. But whether it really prolongs the life of the scope, this has not been really clear in the literature. There are papers which say that yes, because I do not need to push the scope every time in the lower ureter and go up, the risk of damage would be less. But there is also theoretical possibility that when I'm bending the scope, the edge of the excess sheath can damage the covering of my scope, and hence it could cause external damage to the scope. So there could be a deterioration of the outer cover of the scope because of the mechanical contact between the tip of the excess sheath and the scope. This usually happens when you need to reposition the excess sheath. When we are doing flexible ureteroscopy, you must have realized that occasionally the flexible sheath slips out, the excess sheath slips out. There is a tendency to try to push the sheath over the flexible scope. One, definitely do not do that. If your excess sheath has come significantly low down, remove your ureteroscope, put in a wire again, put in the stylet, and reposition the excess sheath under fluoroscopy. But if you want to reposition over the scope, see to it that the scope is not bent. Like in this image, we see that with the scope bent, when I'm trying to push the excess sheath up, the edge of the excess sheath will definitely traumatize my scope. So I should at least keep my scope straight so that my excess sheath goes up. This you do only when you are very, very confident of what you are doing. Otherwise, the better way, as I've said, is stop, put a wire, put a stylet, and reposition under fluoroscopy.
Yes, sir.
How you hold the scope is also important. Now, in this image, if we see the scope is going, sorry, the scope is going down here, bending here, and then going up in the excess sheath. So there is one kink here, then there will be one kink at the UV junction, then there will be one kink at the psoas, and finally there will be one kink in the lower calyx. So these multiple kinks in your scope would damage the scope. So when you hold the scope, this curve should be a gradual curve and not an extensive curve. What this means is that I should stand slightly more behind from the patient, not very near the patient. And further, the tabletop of the patient should be at the level of my hips. If it is very low or very high, there would be a kink in my scope. So properly positioning the patient's tabletop is again extremely important. Laser is definitely the most important equipment we have during flexible ureteroscopy. but it is also an important cause for damage to the flexible scope. So before using laser, it's extremely important to check the laser properly. See that the aiming beam is absolutely circle. See the laser fiber through a laser scope and see that complete light is seen in the laser fiber. And further, when you store the laser fiber, do not put any metallic instrument over this, because the 200 micron fiber that you use can get traumatized even with the smallest metallic equipment. How much should I strip the fiber? So definitely stripping excessively is a no-no, because the excessively stripped fiber can break, and suddenly the tip from which the laser is getting emitted can come very near the lens of my scope and damage my scope. So a better way of doing it is that there should be no stripping of fiber, and the blue covering should be seen till the end of the laser fiber. How much energy I use? Now, every fiber that we use has a different maximum energy. The 200 micron fiber, the maximum energy you can go is 24 joules. But when you are doing flexible ureteroscopy, you usually do not need to go above 10 to 12 joules. That is the maximum needed. And in that, most or practically all types of stones can be fragmented. So whenever I start my flexible ureteroscopy, what I like to say is, first I would like to test and taste the stone. So by very low energy and high frequency, I test how the stone is breaking and let the laser energy test the stone, so that I realize how say crumbly the stone is. And based on what happens in my initial laser energies, I may decide to marginally increase the energy. But this energy setup is a definite no, because at this energy setup, the risk of damage to the laser fiber is very high. And also the fragments causing damage to the laser fiber tip is again high.
Yes.
So you do not need very high laser energy. There are scopes which can identify whether the laser is well in your vision. Keeping the laser fiber properly in your vision is extremely important, because if your laser fiber is not properly in your view, you would accidentally fire the laser fiber in the instrument channel and damage the instrument channel. So the laser fiber should be visible at least 1/3 to 25 to 30% of your screen. When it is there, so if it is covering 25 to 30% of your screen, we can say that the laser fiber is at least 4 to 5 millimeters away from the lens and at a safe distance from the lens. And as you can see, my laser fiber is not stripped at all. So the blue covering is always under my vision. So I know that my laser is safe. Again, during fragmentation for large stones, observe what is happening to your laser fiber. So in this first image, we can see that there is a leak of light here. In this second image, the laser fiber covering has got flayed. This is called as double firing effect, where the laser firing is happening from the tip as well as from the shaft. Or sometimes the laser fiber may come very near the lens. So be observant for these situations. And when these situations arise, stop, reposition, maybe cut the laser fiber and restart again. Definitely the person who is using lithotripsy uses the foot switch. You cannot allow somebody else to use the foot switch. Don't be impatient. Holmium laser energy is effective, but not necessarily fast. So be there 30, 40, 50 minutes till you properly fragment the stone. This was a very interesting paper where they used single-use laser fibers. In multi-use laser fibers, because the fiber goes through a bent shaft, there is possibility that the laser fiber gets multiple injuries and there can be leak of injury inside the scope shaft. So the risk of damage to the scope is significantly higher. So when they were using reusable laser fibers, 9 scopes got damaged, and when they started using single-use laser fibers, only 3 scopes damaged. So overall, when they calculated the cost of these repairs and scopes, they found that single-use laser fibers were more cost-effective. If we are not using single-use laser fibers, we should trim 8 to 10 centimeters of the laser fiber after every use, minimum 5 centimeters, but nothing less than that. A lot of new laser tip designs are coming up, which will help keep our ureteroscope safe. Like this ball tip laser fiber is a very, very good innovation. This definitely comes in the single use fibers, but this will preserve the inner lining of your scope and prevent damage to your scope. Lower calyx is a very interesting situation because when I go there, I need to keep my scope bent. So the best thing to do is reposition your stone in a more favorable calyx. So here I'm holding the stone in Dormia basket, and from the lower calyx, under fluoroscopy and visual control, I'm repositioning the stone in upper calyx. When I do this, the rest of the procedure becomes with the scope straight. So fragmentation of scope stone becomes easier. Deflection is the most frequent reason for ureteroscope damage. You see, when you deflect, you need to look at these three images. Let's look at C1 first, when the deflection is 90%. When the deflection is 90%, your position would be comfortable as the position of C2 on the rowing machine. With this position, you can sit full day without getting tired. But if you have a deflection as big as A1, your position will be like A2. And there is a limit to how much time you can stay in this position. And definitely you would tire or break your muscles. So this is precisely what happens when we overbend the ureteroscope. Further, if the scope curve is less than 9 millimeter, there is a theoretical possibility of laser leak through the laser fiber inside the scope and damage of the scope. When we are using hand instrument, the same principle applies for a hand instrument that applies for laser fiber. Don't let the basket and the stone come so near your scope lens. This can traumatize. So ideally, the basket and stone should be slightly away from the lens when you're removing the stone pieces, so that inadvertently this stone doesn't traumatize the lens of your scope. We should definitely have different types of scope. We should have scopes which have the instrument channel at 3 and 9 o'clock position. This is important because in gravity position, in when I'm trying to work in the lower calyx, when I'm working on the right side, the stone fragments would go towards 3 o'clock. When I'm working on the left side, the stone fragments would go towards 9 o'clock. And if I don't have two different types of scopes, I would end up excessively bending my scope and traumatizing my scope. Are digital scopes better than fiber optic scopes? No. A lot of studies have said that though the vision is better, the work is better and faster, but the overall longevity is nearly comparable. Uh, uh, you should use a proper port seal. If you don't use an authorized port seal, the port seal itself can damage the laser and cause risk to the scope. At the end of the procedure, a leakage testing is very important. If you find leakage, this is the time to get your scope repaired, because once the leak increases, the expenses for repair also increase. Disinfection and sterilization is the time when you can traumatize the scope a lot. So when you are doing disinfection, it is important to have a dedicated sterilization nurse who knows how the sterilization is to be done, and she is responsible for the sterilization procedure. If you have a dedicated person doing this, your longevity of scope is likely to increase by 10 to 20%. Post procedure storage is again very, very important. It should be a large container which holds the scope. There should be no acute bends. The width should be at least 16 inches so that the scope is comfortably inside that box. And once the scope is there, it is when you close this box, see to it that you don't land in such stupid accidents. Training your staff as to how to manage the scope, what to do during procedure, what to do in post processing is extremely important, because a trained staff will take care of your scope better and would not be adventurous and harm your scope, and you would end up losing your hard-earned money. So to conclude, before I start the procedure, I would always check the scope. I would check the deflection. I would check the image quality. I would confirm that my nurse had done a leak test at the end of my last procedure. When I'm putting in the scope inside, I need to be very ginger, very soft, and very slow. Don't push the scope in. Be very, very gradual and soft while putting it in. Laser fiber should be inserted only with the scope straight. If the scope is bent, laser fiber can damage the inner lining. Avoid laser fragmentation with the scope in maximum deflection. Lower pole stones are better repositioned in the upper pole or a favorable position before you fragment. Maximum deflection for prolonged period is to be avoided, and you do not need to go above 10 to 12 watts. Anything less than that would fragment most of the stones. I thank you for your patient hearing. It's been a pleasure being with all of you. Thank you.
Thank you, sir. More than 170 are online. I will ask you some couple of questions. It is also my area of interest. Also, we will share some interesting things. First question is, this is a which scope you commonly use, because this is a forum we want to be as truthful and we want to give an idea to the juniors. There is no conflict of interest. I have used Starge, I have used Olympus, I have used disposable scopes. What is your favorite now?
You see,
No problem, sir.
no,
If
no,
you
no.
tell two, no
There is a
problem.
reason why I smiled. I'll explain that. I work in a corporate hospital where I don't decide which scope is bought. They would take my opinion, but that opinion is really not necessarily be followed. Okay. So what I feel is that it really doesn't make much difference which scope you use. Our mind is so well trained that, say, you are used to initially say a scope where the scope bends down when you put the deflection down. Now you use a other scope, you get used to it within minutes. I have used
Yes, sir.
all types of scopes. I have used Olympus, ACMI. Now I'm using Wolf. I'm very happy with both Olympus as well as Wolf.
Okay. Second question. After doing 5,000 or maybe more than that, I feel that given choice, if the ureter is accommodable, I like to put access sheath and do the surgery. I feel gut feeling that my scope movements are better. What is your opinion?
I 100% agree.
Third question.
So
Yes, sir.
my non-access sheath procedures are very, very rare and unusual.
That's all. Answer.
I am the first person to stage the procedure whenever I feel I am in difficult situation.
Yes, sir. Yes,
You can always come back another day and fight.
yes.
There is no ego issue in endourology.
Sir, in my hospital, it is because it's my own hospital. If I stent, I may charge 3,000, 4,000, 5,000, and do not take any charge even under general anesthesia. What corporate problem? I am not asking what you do. Is it a problem in the corporate to convince? First of all, convincing three times is your personal problem, not related to corporate. But what about the charges when you do stenting? Okay, you explain the patient and satisfy, next time you do very well, you know that. But what about the charges in the corporate average, because you have experienced 2 3, how much it will cost if you postpone the surgery just by stenting?
So I'll tell you what I have been doing because I have been working in corporate hospitals for now nearly more than 2 decades. I have understood the systems there. Okay. If you look at the charging pattern in my hospital, I hope my CEO doesn't listen to this interview. I have made 5 different types of ureteroscopies. Okay. There is a simple ureteroscopy, difficult, complex, redo, staged. There are 5 different types of ureteroscopy, which only I understand what this is. If I say it is simple, it is charged simple. If I say it is complex, it is charged complex.
Okay.
So that is the first thing by which I have tweaked the system.
Okay.
Okay. Second, what we do is say at Fortis Hospital, there is something called as level of surgery.
Okay.
So if I go in and do the flexible ureteroscopy in one go, so I've gone in, I could place the access sheath, I have removed the stone, I have placed a stent. This becomes a level 5 surgery. But suppose I go in and I'm unable to enter in, I have placed a stent, come out. Stenting becomes a level 2 surgery. And then next time when I do the procedure, it becomes a redo ureteroscopy where it becomes a level 4 surgery. So
Okay.
level 4 and level 2 charges are practically equal to level 5 charges.
That's all I want. Next, we'll go to the next
Yes,
question.
yes.
The pre-stenting, do you recommend in all patients or no? I mean, it's a question asked
I
by
do not recommend
Praveen.
pre-stenting.
In
I
all,
do not recommend
yes,
pre-stenting.
yes, yes. Okay.
But if when, as I've said, whenever I have difficulty, I stent and come out.
Yes, yes, yes. So not recommended in all cases. So Anurag
No.
Yadav sir has asked, why should we trim the fiber 5 centimeters in between the cases? I don't do that. Unless I feel that the
So
efficiency of the fiber is very less. We will easily find out by the sound, by the vibration, by the amount of the stone volume that is degraded. We can easily find out. Usually happens after long usage. What is your opinion?
So suppose I'm doing a lower calyx stone, which I have not been able to reposition,
Yes,
and I
sir.
have taken 20, 30, 40 minutes in the lower calyx.
Yes, sir.
After this procedure, I will definitely trim the fiber,
Okay.
because my fiber has been in the bent position for 30,
You
40
have
minutes.
mechanical damage.
Yes. But say I had a upper calyx stone, a small soft stone, which did not take a time, then maybe just half of
That's
one
a
centimeter
fairly
is
good
more than
answer.
enough.
That's a fairly good answer, sir. Samir Palmer asked, what is the best method for scope sterilization? Does the method of sterilization impact on scope life? Very important question. There are not many papers. I have seen that continuously if you keep in Parasef, which I am using for 5 years, scope longevity decreases is my opinion. What is your
So yes,
opinion, sir?
this is a difficult question to answer. Okay. This problem arises when we are doing multiple surgeries in a day.
Yeah,
So usually I try not to keep more than two cases in a day.
better.
Okay. Uh, we get our scopes ETO sterilized.
Okay, okay.
But if I have to do multiple procedures, then I have no option but to use Paracep. And I agree with you that that's not the best way to sterilize the equipment.
Yes. So,
Sadly, I don't have access to Sterad, but if some anybody has access to Sterad, that would also be
I
a
have
brilliant option.
I have a bigger mission steroid. I am using only steroid now. Slightly, and unless see these are proved by papers, we cannot say. But experience also matters.
Absolutely.
The steroid has increased the longevity for me when compared to Paracef. This is my entire team opinion. It's not my opinion. So, steroid is not cost effective. So ETO is better. And for practical purposes, for all those listening, we all use Sidex and Paracef. My word of saying is that Sidex is slightly better for the longevity. Today we are discussing about the longevity issue. So Paracef
So
has
you
mild
see,
corrosive effect.
before I would add one more thing here. You
Yes,
see,
sir.
keeping the equipment in whatever chemical you decide
Yes,
is
yes.
one part of it. But more important than that is
Washing.
proper cleaning.
Yeah,
So proper cleaning and flushing out all the debris and small clots,
yeah.
proper drying. These are also equally important things for the scope life and for preventing infection to the patient
Yes, yes.
than say your mode of sterilization.
Yes, yes. Again, Samir has asked individual nursing home on sterilization. If you want to recommend, I recommend Sidex now. After a large number of cases done, there is no because ETO also may not be there. So that is what answer, Samir. You agree with me, sir, Pankaj, sir?
I agree with you.
Uh, So one important question I want to ask you, very important question which I face regularly. When you pass a laser fiber after, for example, 30 cases, in the flexible scope at 15 centimeter junction, some amount of resistance comes. Then we flush and then rotate and then it goes inside. Even in straight position. Even that time probably the ball tip may use, but ball tip is only one time usage. We don't have any disposable, at least in India. So what do you do in such cases? There is
You see,
nothing.
you need to really look at the scope whether you have caused any dent from the outside. Outside dents would be an important cause for your equipment not going in freely.
Yeah.
I agree with you that there is not much you can do. Gradually
Yes.
maneuver and
Maneuver.
gingerly do whatever you need to do,
Yes.
but not
Till
much
the
to be
scope gets
added there.
damaged, you use it. I mean to say, but
Yes, yes.
you have to be. That's one Oliver Traxler's common statement is that let us share our knowledge. Like if you trim the fiber which is glass is more like a knife, so don't trim it. The blue one slides in small irregularities easily. That's what he says. Don't just cut it off and use. If you trim the tip of that glass
Yes.
one,
So that is precisely what I said, that don't strip the fiber,
yes, don't strip the fiber,
cut the fiber.
cut the fiber. So answer is
Yes.
that. So everybody
Yes.
accepts that now. So we
Yes.
have to accept that. All the juniors don't try to strip unnecessarily, waste time on that. Blue is blue. Only thing what Pankaj sir has shown is that certain times double firing can occur because of the flopping effect of the blue. Realize it and cut it off a
Absolutely.
few millimeters. It takes only 1 minute time. Take it out and
Absolutely.
put it again. Sir,
Yes.
what basket you use routinely for relocation? Yes, मान लो
I love
1 centimeter
engage.
size in circle, what size, Dakota?
No, I love engage.
Engage.
Engage works
Yeah,
very well.
engage.
The
So
biggest advantage of engage I find is that you can release it whenever you want.
release it. So engage type
Yes.
of basket
So
there is in Dakota also, from the Boston
yes.
Scientific, which is 1.9
Yes.
French. That is also good, sir. Same purpose it will serve.
That is very good.
Very good.
It can means it has two levels of opening. So
Yes,
at first level it would open to 8 millimeters,
yes.
and then you can further enlarge it to 1.2
That is
centimeters.
the most beautiful part. It catches well, very well.
Yes.
Catches well.
Yes.
So
So
for the audience,
I'm not really worried about catching.
yeah,
I'm
release it.
more worried about releasing.
Yes, 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 sir.
So I want a basket which releases more
Yeah.
easily.
There are only two baskets as sir told. Triprong type of baskets which are doesn't have triprong is Engage and Dakota from the Boston side. Engage is from the Cook and Dakota is from the Engage is 2.2 French and this is 1.9 French. So
Absolutely.
do if you have lack of vision during the surgery, uh, any tips you give? You wait for some time, slowly flush, you don't fire without vision, anything, something tips when some amount of the haziness and some amount of the bleeding if it is there, sometimes we misfire and unnecessarily damage the scope. What is your take on it?
So I 100% agree with you, Dr. Chandra, that you fire only when you see properly.
See it.
So that is number one.
Yes, sir.
Increasing the pressure of irrigation may increase the bleeding.
Yes,
So just to clear off the blood, increasing pressure of irrigation may not help.
may not help.
Give it a break for a couple of minutes. Say if you have, luckily, suppose 2 stones.
Yeah,
Initially, I was working in the middle calyx.
yeah.
There, the vision became poor. I may, for some time, go in the upper calyx, give rest to this calyx, and then come again here.
Yes, sir. So outflow also, I feel outflow if it is coming well, then this problem will not be there. If you have outflow problem, come out and recheck whether everything, and the flushing person also, as sir said, should be careful. The question asked by Vikram Nimbur, do you recommend use of saline pump always? Nowadays it is decreased. What is your opinion, sir? Pump.
I strictly don't use a saline pump.
I am
I
also
don't
not
use
using.
a saline pump.
So
Yes.
please take it for granted.
So
Nowadays, I think no senior is using saline pump with pressure. Now the Jamana has come to natural gravity drainage.
So, Dr. Chandra, what I tell the juniors who work with me is that
Yeah.
flexible ureteroscopy is one procedure where you should learn to do in slight hazy vision.
Yes, yes,
If
yes.
your vision is crystal clear,
That
then
means you are pushing.
probably your irrigation pressures are very high.
100% correct point this is. I also
Yes.
strongly agree. Very, very valid point, important point. Don't try to have a great vision. Conferences, that is all different. See, many of the surgeon seniors sometimes to get fluid out, they say flush, flush, or in PCN also. That all causes intrarenal pressure raise. It will have impact in the post-op. In your day-to-day practice, don't try to have the best vision. Outflow should be good and minimal flow which can see you the stone and finish the stone. That is.
Absolutely.
So
The aim is only to clearly see the stone.
yes, last couple of questions. What is the largest stone you select usually, because a person who can do PCL and RIRS equally well, that's why actually I went into supine PCNL deep, because instead of changing position more than 2 centimeter something tricky situation, I immediately go for PCNL. What is your opinion like?
I 100% agree with you. So I look at two things. I look at the Hounsfield unit and I look at the size.
Yes.
So if the stone is say 600 Hounsfield unit and maybe 2.5 centimeters, I may be able to do with flexible
Yes,
ureteroscopy.
yes,
But if it is 1500 Hounsfield unit and 15 millimeter in lower calyx, I would prefer to do a PCNL.
yes, sir.
So
I
the
also,
site of the stone, size of stone, and Hounsfield unit.
yes,
These are three factors which will help me decide.
I add with my experience one additional point. Even your scope is in when seeing the stone. If it is very difficultly seen, I will immediately abandon.
Absolutely.
You can't do any stone with a very difficult position that puts strain on the scope.
Yes.
Sometimes even a very nice looking stone may not be reachable. There is no point pushing and pulling and pressing the scope. That is what sir told, that don't strain on the scope by any means. It is of no use.
You see, let me re-stress one point that in endourology, let's not have any ego issue.
Yes,
You see, if we survive, we can fight again tomorrow.
yes,
So it is better to survive today so that we can fight tomorrow.
yes,
I will just tell you a small story of
yes,
a
sir.
recent example.
Sir.
One pediatrician was referred to me for RIRS for lower calyx stone.
Yes,
At least 3, 4 urologists were involved,
yes,
and the patient had come to me only for RIRS
yeah.
because there were 5 people, all who were very good in PCNL.
PCNL.
Now, such situations put stress on you
Yes.
because you need to do RIRS at any cost.
Yeah, yeah.
Avoid such situations.
Yes, yes, yes.
So, despite this being a pediatrician, despite there being 4 urologists, despite there being a pressure on me that he has come to you only for RIRS,
Yes.
I was very clear to him that I will try once. If
Yes.
I'm able to reposition, otherwise I'll do PCNL same time.
Bus, bus.
And that is what we ended up with doing. We ended up doing PCNL.
Then on that day you should feel more happy.
Yes,
Feel more happy that you have done perfect procedure without complication.
absolutely.
Had it be a surgeon who has done 100 procedures, if he is feeling difficult, means it will be difficult for anybody.
Absolutely.
Difficult for anybody, more than 100 surgeries. Once you acquire certain skill, it will be difficult for anybody. So there is no point trying too much hard for that. Excellent
Absolutely.
point, sir. Sir, last question. Uh, on an average, uh, couple of, this is mixed question. On an average, you say how many number of cases you are getting with your scope. Vague question, but everybody wants, sir, how many cases it will come, they will ask. I say 50 to 60. Second question I want to ask you is, uh, these scopes, do you think that individual person, like you said in the this thing, should maintain their own scope and then see that no other person uses them, so that you can maintain the longevity? This is the last question I wanted to ask you.
You see, this really will depend on what your overall team's experience is.
Yes, sir.
Okay. Suppose there are 3 urologists who are equivalent to me in my practice,
Yeah, yeah.
and I have confidence in their capabilities,
Yes,
then there is no harm sharing the scope with them.
yes, sir.
Say, if you and me are working together, I know you would take care, you know I will take care.
Yes,
So
sir.
there is no harm we sharing the scope. But if I am working with a absolutely new person whom I am not comfortable with,
Yeah, yeah.
that is the situation I would want to segregate the scopes.
Yes,
Because, finally what happens is that you may work and put the scope to the brink, and it may break when I am doing the procedure.
yes,
So on paper, it goes damaged by X person.
yes,
So no harm in that. But still, if I use my own scope and I manage my own scope, I would be able to give much better results
much
than
better results.
letting it be used by people whom I don't have confidence in.
Yes, yes, yes. So, for all the audience, the important points are discussed. Sir has made very clear, very frank, very practical points. I hope it will be very useful. Thank you, Pankaj sir, once again for sparing valuable time. These type of discuss. In fact, I asked you for 3 talks. One is, my first wish from you was holep, 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 because you do it very well. Second was the complications videos you have in PCNL where none of the people record it. And third is flexible ureteroscopy. You have chosen third. These two in the coming 3 4 months we will do it again, because good speakers with documentation and evidence are less. I can't get 365 days 365 speakers, it's impossible. So we will have repetence with good speakers. I wish we will see you again. For the pure FB viewers, tomorrow we have lap donor nephrectomy by one of the senior most and who has done the highest number of donor nephrectomies probably in India is Dr. George P. Abraham sir. So exclusive surgical technique I told on lap donor nephrectomy for various right or left. He will demonstrate tomorrow with his talk. Today I thank Pankaj sir for giving such a good lecture. 210 people are watching the program. I thank you very much, sir, once again. With this, I will conclude the session, sir.
Thank you very much, Dr. Chandra. I hope you continue your good work.
Yes, sir.
Whenever you need me, I would be very, very happy to
Yes,
join
sir.
in your
We are supposed to do an HOLEP workshop. Somehow I missed 1 or 2 times. Let the COVID go out. I'm very interested in doing live workshops. Still, I missed you. One of the few I missed in India. Let us hope HOLEP demonstration will be done at Preeti Hospital sooner.
It will be a pleasure. Thank you so much.
Thank you very much, sir.